Professor Vivek. Okay, so I will just few photographs for my own, in fact, satisfaction. This is the time when I was working with Srl 1996 to 98, and just a quick thought process, very nice stay for me. At that time, the concept was there in the mind of Dr. Trivia, 96, that it was not done. And recently we celebrated the 20th anniversary of the first case. I was there, and this was in the chapel. You can see few photographs there. With a lot of people, including Ronek, Shah Fajade, Sirat was there. These were some photographs which were displayed in the museum. My family, myself with him. So I wanted to show this thing because it was actually a real pleasure to be there on 20th anniversary at the museum in the evening. So a lot of people were there from America, and this is an interview which I just had a small talk with him just a day after that, and this is on the YouTube available. So coming on to the birth of this, and a few slides I've taken from Professor Trivia also, and this is what the predisposing factors to the birth of TAVI Rua, Srl Cardiologist personal journey. In fact, it was 1985 when he did the first aortic valvuloplasty, and that time he already became a celebrity. So this was the team which actually led to the formation and planning of this day. Dr. Ronek Winning, Dr. Can I have the marker? So you can see the team, Dr. Trivia, Bala, Ibrahim, Ronek Winning, Ellen Alshangav, Jaramo. A lot of people might be known to many people here, a lot of people may not be known to this. This was the team which I was working. Now coming to the presentation. So scope of problem of degenerative aortic stenosis, I'll just touch upon. 26% of population of the age of 65 have mild, moderate or severe aortic stenosis, 2% are symptomatic and should require treatment. It is estimated that within 15 years the number of aortic stenosis patients will nearly double, especially with the aging population. It's a degenerative aortic valve, which we're talking. Surgical intervention should be performed promptly once even minor symptoms occur. The prognosis of AS not significantly changed in 1960. 30% deaths within 3 months in patient waiting list for TAVI. 13% of deaths within 3 months in patient waiting list for TAVI. And surgical intervention actually reduces and in fact completely allay the problem of death. In standard patient, mortality after AVR is low. Mortality and morbidity increase in patients with associated risk factors, age, ejection fraction low, combined bypass surgery or comorbidity. After successful valve replacement, patient lifespan returns to that general population, and that's the beauty of this disease. When you do valve replacement, either by TAVI or TAVR, whatever you say, or by surgically, patient comes back to normal lifespan. So this was 1985, when as such AVR at that time was not considered to be a good option in the elderly patient. 72-year-old woman, highly symptomatic, several daily syncope, decline for surgery, and this was the patient which was actually done in 1985, published in Lancet in January 11, 1986. And this was actually the first time anybody had actually attempted to open the aortic valve with the help of balloon. So this was known as Krieger-Lattak balloon. Initially, Lattak was a professor in the department. In the same department, Krieger was number 2 at that time. And that's why the name of the balloon was Krieger-Lattak. Balloon aortic valvuloplasty in 90s, of course, we know that it has a restricted indication because of restenosis, and that is why now it is only being used only for the purpose of bridge to TAVI, that means before TAVI. Solving these issues, because it was a restenosis, which was a big problem, that became a sort of an obsession for Srl Cardiologist. And during TAVI, BAV has become a simpler and safer percutaneous technique, especially now with the rapid ventricular pacing at the time of balloon inflation. So, 1985, famed balloon aortic valvuloplasty tried to enlarge the aortic valve orifice by balloon calibration, and that was done in 1985. I think I am repeating the slides. And let me come to the what to do next. That was the main aim. 30 years later, BAV is now being used for the before TAVI as well as rapid ventricular pacing, and BAV remains part of many TAVI procedures, pre-calibration and balloon sighting. Coming on to the development of this TAVI from 1985 to 2002, when the first case was done. So there was don't undertake a project unless it is manifestly important and nearly impossible. So this was a project which was almost impossible in the minds of many people, and this was Edwin Land at that time. This was a project which was almost impossible. So a single goal for these two innovations to provide a life-saving therapeutic option for patients with symptomatic AS and decline for surgical valve replacement. At that time, it was not for the low risk, it was only high risk. So in 1980s, SAVR was declined in all patients older than 70, 50% of symptomatic patients, attempt to solve a major unmet clinical need. Goal was to improve the results of VAV, that means you should not have restenosis. It was highly challenging because of valvular calcification, surrounding structures, coronary arteries, mitral valve, IV septum, his bundle, and major clinical issue at that time was coronary occlusion, mitral valve injury, permanent AV block, stroke, AR, prosthesis ligation, and long-lasting results. The part of the concept is stented valve aortic stenosis. User observation during VAV, any calcified valve can be centrally opened by high pressure balloon inflation. A balloon expandable stent with high radial force might keep the valve open. A valvular structure would have to be attached within the stent. A balloon expandable stent with high radial force might keep the valve open. A valvular structure would have to be attached within the stent. A challenging combination of balloon expandable frame and valve structure, and that was actually required. In 1994, the top study, balloon expansion force, frame distortion, optimal dimension, extraction force, a circular stent opening, high tension force to dislodge the stent. So this was the optimal dimension of the frame. You can see the coronary ostia diameter 23 mm. Height. This is actually a picture of an autopsy study from where is there. IV septum and mitral valve. So these are the structures we were taken in consideration. 1994, the drawing area conceiving the model of transcatheter valve. From 1994 to 2002, there was 8 years which were lapsing before the starting of the planning and engineering, and then of course finding the possible way. The birth of IVF TAVI was most challenging basic concept, implanting a valve processes within the diseased calcific native valve on a beating heart using regular percutaneous catheter-based technique and local anesthesia. Impossible was the structure, dangerous surrounding structures, coronary ostia, mitral valve, his bundle. So from the idea to the validation of concept, and this was, you see, this was already said, I was told that this is the autopsy study from Renu Vermani, Washington DC, confirmatory finding the height, mitral valve, and respect the adjoining structure. Filling the stented valve, the procedure of TAVI, valve structure, biological or polymer, high radial force, balloon expandable stent, external curve, hand-made model of THP with Professor Gussu. Gussu was a cardiac thoracic surgery head of department, came diameter 8 mm, transfemoral approach. This was all the concept which was going. From 1994 to 1999, that was big problematic period for NIC because he was looking for a sponsor. And what was the coming from experts from all biomedical companies, including Edwards and Medtronic, who are selling this valve like hotcake today. They said, totally unrealistic, major technical issues, definitely impossible to stent a calcific aortic valve, unavoidable life-threatening complication. And they also said, most stupid project ever heard. This was an email message from most of the both from these two companies, Edwards and Medtronic. Most stupid project ever heard, just forget it. That's what the end of the story in the mind of Dr. Trivia. Then what he did. Project was subject to all these things, totally dangerous, forget it. Then they did a foundation of PVT, percutaneous valve technology, which was a company which was based in New Jersey, USA, along with Martin Leon and Robin Welchik. This was the time when they sought to found a company sponsored partially by PVT, and then they did extensive laboratory animal programs, sheep model, acute and chronic studies, and then they finalized a device which is tri-leaflet bovine pericardial valve, stainless steel stent diameter of 23 mm. This was the PVT which was finalizing the device, and that project of TAVI is still alive. They were happy. This was started for them, especially this Dr. Rove and Dr. David Walsh, along with Martin Leon and Anna Krivier. December 1999, signed an agreement with RNRD, Israel Investment and Development. This was Israeli people who had actually sponsored the program. Request to the engineers, a processing made of highly resistant frame containing a unique bio or tri-different valvular structure able to be homogeneously compressed over a high pressure balloon and large by balloon inflation for an external of 23 mm without damaging the frame and valvular structure. This was the planning which was given to the engineers, and finally engineers designed it, and they found that durability, resistant defect issue. So this was the engineer, and they built it. So this was actually PVT, Israeli engineers working on it. From 2000 to 2022, the PVT valve pre-clinical evaluation was done, and this was tri-leaflet valve, polymer, then bovine pericardium, stainless steel stent, single diameter 23 mm, 24 French crimp size. So this was the diagram and designs which were done. By that time, in vivo testing, the sheep model was done in Srl, which is a Srl is like ICMR of France, and this was done in Srl in Paris from 2000 to 2002, especially the sheep model. EHP implantation animal model was limitation, fairly simple in anatomy, but size of the heart, aortic valve anatomy, proximity of the organ structures, even minor difference in physiology anatomy can lead to profound differences in treatment safety. The efficiency was there was no aortic valve calcification in the sheep model, and there was no aortic valve degeneration. It was a different arch anatomy. But still, moving to human was the most difficult decision to make. And of course, that eventful day we all know, April 16, 2002, and that's why I said recently they celebrated 20 years of TAVI in Rouen, France, in Chapelle. First in England, implantation of aortic valve was done. 57-year-old cardiogenic shock, EF of 12%, multiple comorbidities, intraventricular thrombus, aortic bifemoral graft occluded, no femoral access, turned down by 3 surgical teams, failed emerged transseptal PAV, back in shock in 24 hours. Challenging decision of transseptal TAVI as a life-saving procedure. All current contraindications of TAVI, was there at that time, and of course this patient was treated by him, and he was telling his own story recently in Rouen, 21st of May, when the program was held. He said he could not sleep that night because it was planned for the next day. After the email consent from Martin Leon, he said he could not sleep in the night, and after performing the procedure, he went to start to smoke, and then came back, and he was visiting the ICU again and again after doing the procedure, whether the patient was still alive or not. He was saying that. So this was actually a serious decision taken in concert with Martin Leon to do such procedure, and first in man, and it was successful. You can see the picture of 30 minutes post-implantation, 8 years post-implantation, and then of course the lesson was that it was feasible to do it. No embolization, no coronary occlusion, no mitral devastation, no heavy heart block at that time, in that patient. Mild AR, optimal valvular function, immediate hemodynamics and clinical improvement. This patient lived for few years after this. And therefore from dream to reality, you can see this was actually a dream which turned into a reality. It worked in that patient. It was through the transseptal approach from the femoral vein, going from the atria, right atria, left ventricle, and then the aorta in a retrograde, in an antegrade fashion, and then they did it. While positioning, it was not easy, and finally they did it. So from 2002 to 2005, I'll give you a little more historically before I finish it. There was a heroic period in Rouen. Only 40 patients were done. 2002 to 2005, and there were 2 trials, I-Revive and recast trials. Only compassionate use. There were those patients who were imminent death. Transseptal approach in 85%, retrograde approach in 7, 3 failures. Challenge was to demonstrate the potential benefit of a disruptive technology on a subset of critically ill patients and life-threatening comorbidities. And of course, at that time, it was published in JACC in 2004 and 2006. There was a Kimpic device, Newman Peru, 24 French sheet, not 14. 24 French sheet. Patients survived more than 5 years, and few patients survived for more than 6.5 years. And there were few important patients which I would like to show, which are Dr. Krieger always tells, that 83-year-old lady, and there was no device dysfunction. Creatinine came back to 12, and this was presented in first year post-TAVR in PCT Washington on 2004, and then of course 2 years post-TAVI, the same lady, 6.5 years post-TAVR 2010, again she was presented, and the patient was doing well. So these are few patients of the heroic period where the patient was on. There was no, at that time the trials had not started in America. So these were few patients which were very important, and therefore Dr. Krieger is very proud. From TAVI takes a flight in the world, and that was in 2005. 100 TAVI performed. It was deployed. Dr. Martin Leon, Napier, Patrick Serraz, Rotterdam, Milano, Antonio Colombo, and of course John Webb, who started the first series of retrograde approach from Canada and Vancouver. So this was all history. Edward Life Sciences now, the same company which had refused the idea and acquires PVT. PVT was born to develop this valve, and now this is acquired in 2004 by PVT, and Krieger Edward Wall was named as Edward Sapien Wall, and of course you can say John Webb came in picture. Retroflex sheet, scalable delivery system, European industry, including Rose, Source, and partner US trial started. From 2006, advanced technology, delivery system, third generation retroflex sheet, and nose cone, they were all started because of now retrograde approach. And alternative approach to transapical access was also developed, but of course now being almost forgotten, transapical with the surgeons going up. Launch of concurrent device, the self-expanding core valve started in 2004 with Grube, and Lombardi, and Jacques Sapien. and they had a 21 French sheet, smaller sheet size, and this was, of course, we all know, was a self-expanding, not the balloon expandable device. At this stage, nobody would have predicted the incredible success and fast expansion of TAVI. Reason of success: improved device technology skill, better team experience, better patients, better screening, MSCT and new technologies, thanks to the constant support of the industry, vascular approach, anatomy, and this. So this is the skill which started, and as I told you, that Edward Sapien and Edward XT and Sapien 3 and 12, and on the other hand, Medtronic takes the core valve, and of course they started developing the Evolute 1. So the reason was that the companies actually invested heavily, and of course to develop this, and they found that there is a reason to invest because this is going to be. At this reason of success: improved device and technology skill, transfemoral approach, default strategy. 2021, 92% of cases was done as a consequence of advanced technology. The transfemoral approach makes the process simpler, faster, safer, and increases the number of potential candidates of TAVI. The second thing, TAVI is turning to stent-like procedure since 2009 with the launch of Sapien. The minimal transfemoral approach, only conscious sedation, no general anesthesia, no need for the anesthetic inside, only surgeon should know. Procedure duration is 30 to 40 minutes. Patient discharged in around 3 days' time. All patients of Rouen, which is in France, the work of the Cardiologist Srl Hospital, Series had TAVI performed with local anesthesia and mild sedation. We had patients who did in 2011 the similar way. Better experience, and then of course initially fiercely opposed to TAVI and the local sedation, now convinced. America, which was fiercely opposed to TAVI and the local, now convinced, and they did October 2017 TAVR exercise history, and they did 80% consolidation. So large body of scientific evidences is the other reason why this is now so being done. Multiple TAVI registries, high risk, mass registry versus surgery, intermediate risk, evidence-based trial, inoperative, high risk, intermediate risk, and low risk. These are all the trials which have started happening at the same time, and the proof of concept you can see with the registry, as in the film of the proof of concept, 2003 small series, 2005 and 2007. Of course there was a trials, and then of course the French aortic national core valve annual registry published by Elshine and Martin Gilla, who was the president of French Faculty of Cardiology at that time, was published recently. So 27 ancillary studies followed by France TAVI. So large body of scientific evidences. Bermuda Triangle study, which was 3,000 patients, TAVI in 72, TAVR in 282. This was a randomized trial published in ESC 2012. Not many people know about this. Similar scientific pathway with valve, core valve. They did the part. Then, of course, evidence-based trial. This is a trial which I would like to tell you. Partner 1, Partner 2, and Partner 3. This was a trial which started in America, with of course with collaboration with the French people and other European people. Multi-centric trial. Partner 1 was for inoperable high risk. Results 2012, and FDA gave approval. Partner 2 was 1,200 patients, intermediate risk 2006-12, 2016. The results came, FDA approved, Sapien XT. Partner 3 was a low risk, more than 75%, 2019, FDA approved for the low risk. The Partner 3 was showing the non-inferiority or superiority of TAVI in these cases of it. The FDA approved it. This is August 16, 2019. The hypothesis of TAVI, the most hypothesis of TAVI. The FDA approved TAVI for the low risk patients, more than 65, both for Sapien 3 and Medtronic Evolute. And they said, with this patient, a spectacular worldwide expansion of the TAVI happened. 1.5 million patients treated to date. 15 lakhs patients have been treated today by the TAVI procedure in more than 70 countries. And the developing TAVI, a bulky, long road for Prepare and other people later on who joined him. And you can see from Partner 3 2019, expansion to all comers. 30 years is where VAV, 1985, that was the first balloon aortic valvoplasty. 20 years is fame. The extension of TAVR indications, valve and valve, bicuspid valve, asymptomatic AS, moderate AS, plus heart failure, high risk AR, TAVR with concomitant disease. Of note that this breakthrough technology has opened a new world in cardiology by stimulating the transcranial treatment of many other valvular and heart disease. More than 1.5 million patients have been treated today worldwide in more than 70 countries. What would you have believed this 20 years ago? A new paradigm
TAVI is conceived 2002 is conceived for patients who are not candidates for surgical aortic valve replacement. That was 2002 TAVI for patients who are not candidates for surgical aortic valve replacement. Now, surgical aortic valve replacement is indicated in patients who are not candidates for TAVI. It's just a reversal after 20 years. Thank you very much for your kind attention, and I hope you like this presentation. It's not easy task for even innovator and a cricketer who I always call a graduate of at least transcatheter aortic valve.
Thank you for a great presentation, Dr. Gupta. Let's, you're fine. Let's go to the next presentation by Dr. Harish Mehta. It is regarding the complications during TAVR.